We have the pleasure to welcome Hung Lee, and Mohamed Nosair will be presenting a live-in-the-box complex PCI.
All right, good morning, everyone. Welcome to those that are visiting us from Montreal. Thank you for your attendance. Thank you to the distinguished panelists here. For this presentation, my colleague and I have no disclosures to reveal. Basically, as the schedule was slated, we were supposed to do a live case. So life throws you a couple of curveballs, and I'll show you one very soon. So the objectives today is to identify a chip case, plan the use of percutaneous LV support, review implantation technique, and the utility of transthoracic guidance during percutaneous LV support deployment, as well as talking a bit about managing an uncrossable or hard-to-cross clinical scenario in the cath lab. So this is a chip in a box. So the patient that we were supposed to do today was actually reviewed again by advanced heart failure, and they decided to consult transplant, so that's where we are today. So we ended up troubleshooting and finding a chip in a box case that Mohamed and I did about 2 weeks ago. So when we're talking about curveballs, this is a picture of me last night at 11:10, unexpected C-section of my wife. So you always have to plan for things that you don't want to happen, but then when they happen, you're still there the next morning presenting. Very understandable and understanding wife. So I'm going to talk to you about a very interesting case, and it's actually a nice segue to the conversation that was just had by the panel here about taking a patient off and not doing ad hoc intervention right off the bat, and talking mainly about the patient. And, you know, as an interventionist, those of you who know me, I'm aggressive also, and, you know, we like to do stuff. But when we start talking to an audience and we talk about an osteo versus a distal left main, it's very technical, and that's what we like. But in the end, it's also a patient with an osteo and a distal left main. So let's see what you think about all of this at the end of this case. So it's the story of a 60-year-old gentleman that was referred to us. He had a past medical history of CAD, having been stented in the past in his RCA with a DES. He had a history of stroke, but with no clinical sequela about 5 to 6 years ago. No diabetes, hypertension, or high cholesterol. Still an active smoker, severe COPD, FEV1 of 1.2, and a recent treatment of radiation and chemotherapy for stage 3 adenocarcinoma of the lung. Actually in remission right now. So he presented to one of our referring hospitals, the outlying areas of Montreal, with a exertional angina as well as shortness of breath, CCS class 3 out of 4, and NYHA class 3 out of 4 as well. In his workup, a transthoracic echo was performed. LVEF was estimated around 20%, had a dilated LV as well as moderate to severe MR. So he was ultimately referred to our center for a diagnostic coronary angiogram, which I'm going to show you right now. Hopefully it'll run. So right off the bat, you can see in this areocaudal view that there's a long, eccentric, and calcified LAD, left main going into an LAD with a severe osteal lesion, as well as right off the bat, you see the stent in the RCA. It's mid to distal portion with an occluded RCA, with the distal bed being provided by collaterals coming from the left. Different view now. Hopefully it's supposed to run. Okay, here you go. Another view, another caudal view showing you pretty much the same thing. Again, bringing your attention to that sort of eccentric, calcified, and long left main with a lot of calcium going into the LAD. Gotta click twice for this to move. Again, cranial view shows you about the same thing with a reasonable distal LAD target site with a flow that is not perfect TIMI3, as you can see. And from what you could gather from the previous images, the heart is actually rather stretched with the vessels. I'm trying to move this along. So LAO cranial view shows you the collaterals going to the RCA as well as that long left main. spider view should run. Again, the calcium, and you see the eccentric calcified prox LAD lesion. We'll talk about again with this left main. You hear me come back to the left main because this has relevance during the case. Moving on now to the RCA view. All right. LAO view, you see that there's a severe lesion in the prox third of the RCA as well as a complete occlusion and CTO of the distal RCA prior to the stented area.
And very pertinently, there are collaterals going to the LAD from the RV branch, which are going to be important maybe at some point during that procedure because it gives you at least a bit of security from the right.
That's a great observation. Let's move this on. And to confirm what we had suspected, this is the kind of case where you're like, oof, when I heard this from one member from the panel, long sigh, and the person doing the coronary angiogram was saying the same thing. He's standing right next to me. So what would you do now? I leave this to the panel or the audience.
Needs an MRI.
Life expectancy of that.
He was in remission. That's when the treating physician was called. He called the respirologist, and that's the answer we got, in remission.
So Jean-François, you had a question?
Yeah, is there any viability in that myocardium because
Excellent.
it doesn't move that much?
Excellent. Is this what everyone would do in this current era with the current data?
For
We move
killing him on
towards
the table,
viability
I think we need to
studies?
At least.
I have a couple, even before that. Did
Sorry.
he receive adriamycin for his lung
I don't
cancer?
recall the details.
He did not.
Lung cancer?
He did not.
Not usually.
Well,
Yes.
he looked.
I didn't have the cardiogram. We didn't, but I don't think it was a left bundle or was a. No, it wasn't anything particular. No Q waves, at least, and we'll show you more.
On the TTE, was it like diffused, severe hypokinesia, or you can see some scar? The wall was thick, thin, and the LAD territory on the
The
TTE?
LV anterior wall was not thinned.
Okay.
The inferior wall was akinetic and thinned.
So did you do any viability testing on this patient?
So we agree on this. I'll move along for time's sake. So, do you see the slides?
No, we don't.
Okay. So, this is really very relevant to what we had just discussed before I started my talk. So the decision was made not to proceed with ad hoc PCI. Patient was returned to the referring center to discuss treatment options with the patient and family. Again, talking to the respirologist and the family was key components in the decision not to proceed with anything. The treating physician opted for and requested viability study. So he sent them back to the institute to get a CMR. So this confirmed a dilated LV with an EF of about 15%. There was a viability in the basal mid-ventricular anterior wall, but fibrosis of the apex, a non-viable inferior wall, and only moderate MR.
The
Yes?
surgeon saw the patient before going back to his referring center to have
No, we talked to the surgeon subsequently, not before. We wanted to, actually, sort of a discussion when we talked to the patient on the table. The patient wanted to talk to his family, and then the treating physician is actually one of my ex-trainees, is a very excellent cardiologist, Donato Berri.
Do you remember if the stent on the right was placed in the context of an MI?
Not that I recall. It wasn't
Because
done
it could be
at our
it could be a
center.
stent thrombosis as well. Because the way it looks, it's a long occlusion and stent with collaterals that build up from the RV branch to the PDA and also the LAD. So it sort of tells me that probably he had a thrombosis of that stent, and then now he's got non-viable inferior wall, and basically what you have to focus is to treat the left system, right?
Again, a quick reminder, this wasn't an acute presentation in terms of chest pain. He sort of came in with exertional, progressive angina as well as shortness of breath. So clinical evolution of the case, despite viability in the LAD territory and what we had just, what Stéphane has just mentioned, and due to the high-risk nature of any invasive therapy for this patient's CAD, an initial conservative approach was chosen by the treating physician and the patient as well as his family. So the three dots tell you what I think. But that option soon failed, obviously, and the patient continued to have exertional angina and presented again with shortness of breath and pulmonary edema to the referring center. Recalling what my trainee called, when he called and he said that he had calculated the STS score, which is great for a clinical cardiologist taking the time to do that. This is basically what we had talked about. So we had calculate this for you. I don't know if the surgeons wanted to comment on any of this up to now.
Well, for sure, if you look at the overall picture of that patient, it's a very high-risk patient, and it's definitely something you cannot bring to surgery without thinking about it. And for me, I mean, I would not do a surgery on this patient unless we're talking about just doing a robotic mid-cap to the LED, because those kind of patients, they tolerate that kind of surgery very well, because you don't have to move the heart around, you don't have all the other risk because you don't touch the chest. So that was something could be discussed and decide what we're going to do, but definitely not a standard surgery.
The thing here is, the guy had a stage 3 lung cancer, severe COPD, he's got very bad heart, some MR. So
and
I think
chest wall radiation.
Yeah.
Is that something, even for minimally invasive robotic Lima to the is that something that would stop those of you that
Well, the
do
question,
it?
where was the radiation? Was it to the left side where the ITA is, and ITA could potentially be compromised? So definitely, that's a big concern. So yeah, this guy is extremely. This is a gentleman that you definitely have to disguise a heart team approach,
But I
and
think that
I think surgery for him would be absolutely.
Which we did, and the surgeon. Which we did, and then we got the nod to move towards percutaneous revascularization from the surgical consult that we had. So in terms of management, this decision was to proceed with revas by the patient, the treating physician, and the heart team consult. Decision that the patient was a non-surgical candidate due to important comorbidities. Hence, this patient entered sort of pathway to decision-making for a CHIP case. So very quickly, what is a CHIP case? CHIP stands for two things. The term usually the acronym refers to complex high risk and indicated patients. And more recently, some have started talking about the complete revascularization concept for high risk indicated patient. Again, indicated patient are the key words here. What is complex PCI? Complexity is related to difficult coronary anatomy with many different subtypes associated with increased mortality and morbidity during PCI. Unprotected left main, severe calcification, extensive thrombus burden, bifurcation, extreme tortuosity, degenerative graft, CTOs, last remaining conduits, multi-vessel with high syntax scores. What would we then consider high-risk PCI? Other than a typical STEMI patient, cardiogenic shock, the sort of crash and burn patient, let's call the ECMO team type kind of patient, it's rather operator dependent in terms of definition. One would say that what I or other people might consider high risk, Stéphane might not say is high risk. So again, it's a very operator dependent definition. So trying to put this into a word or into a concept, one could view high risk as a risk profile conferred by the confluence of three factors which are individually surmountable, but when combined, increase the likelihood of poorer clinical outcomes, not just immediately during the procedure, but as well as in hospital. When we think about that, you have to take into account the level of complexity of the coronary anatomy and also the potential for hemodynamic compromise or instability during a revas, percutaneous revas attempt, and also major comorbidities that you have here. So in order to do this, when you talk to, when you think about a heart team concept, we all have to talk the same language. So there's a very interesting paper in JACC based on the syntax as one of the many syntax sub-studies where they sort of cross-tabulated the syntax score as well as a Euro score. And this sort of tells you where these CHIP patients fall into. They could be that red part, or they could be that yellow intermediate syntax but high Euro score, or intermediate Euro score but high syntax score. It's a nice place for people to discuss the indications and how surgeons and interventionalists should view a patient in a common way. Okay, I pressed the wrong button. Again, for the sake of time, I'm not gonna go over these papers, but these are actually in JACC. If anyone wants, I can send you the references. But again, this is a pathway for high-risk PCI, not the use of percutaneous LV support devices in other settings, such as cardiogenic shock or cardiac arrest. I'm going to skip over this for the sake of time. Again, available, there are basically 4 well-known devices, the intra-aortic balloon, the classic one, the Impella, the tandem heart, as well as a VA ECMO approach. So in terms of the management, since this was a team approach, a 2-man team, we try to do complex cases such as these as a 2-man operation. I'm going to hand this over to Mohamed to discuss strategy and the procedure.
So we decided to proceed to a percutaneous revascularization. Due to all the comorbidities we discussed, he was deemed a non-surgical candidate, and it was planned as a CHIP procedure. So let's talk about the strategy. For the sake of time, I'll just proceed. So this was our initial approach. This is how we planned it from the beginning. So we planned to do it with conscious sedation, no intubation, ultrasound-guided femoral access. We plan to do a pre-closure technique for the Impella insertion. We wanted to use a percutaneous femoral Impella. And for the PCI, we plan to go radial. Using a 7 French XB35 with a mother and child radial insertion, the way Stéphane likes to do it. I actually learned it from him. And move forward with rotational atherectomy using 125 and 1.5 burrs. And at the end of the procedure, we were planning to remove the Impella, not to leave him on it. So using the micropuncture technique, we confirmed our positioning. And you want to, for the insertion in the Impella, you want about 5 to 6 millimeters for the CP35. Sure. So the way I do it is I insert a 6 French radial sheath, as you usually would in a radial. Following that, you can either use the sheathless catheters that we have, but I prefer the regular catheters because the curve is not the same and the support is not the same. So you take a pigtail, a 5 French pigtail, because it's 110 centimeters, and your guiding is shorter, so you have about 10 centimeters sticking out. And you just make sure your skin is well open, and then you need to really stick the 2 catheters together at the end so they don't dislodge, and then you insert it over an exchange wire preferably. I've taken out the sheath. And if ever you have bleeding, because it could happen sometimes, you can always put a radial band, using a sterile technique to put a radial band on it. And we had to do this in this case, actually, because it was bleeding around the catheter. Then we performed a femoral angio. As you see, we were lucky that the left side was diseased, but the right side was all good. Following that, we put a stiff wire to insert the 14 French Impella catheter. And it's very important to note that once you insert the Impella sheath, you should not remove the introducer until you have an ACT above 250. Then I proceeded to perform a diagnostic angio just to make sure that the anatomy didn't change since the last coronary angiogram. And as you can see, the left main is very tortuous, and you have an eccentric, very calcified LAD with a TIMI2 flow already. And the same thing you appreciate on the cranial view. So we entered the LV using a pigtail, just to make sure that we're not in the corda. And then we put the 018 wire of the Impella, and then we inserted the Impella and went up very smoothly.
It's an Impella CP you're
using? It's a CP.
Which is 14 French versus the 2.5 that is 12 French.
Exactly. And as you can see, the radio-opaque markers You want those close to the aortic valve. And here it comes tricky because if you have a normal LV, it's pretty simple to position. But in this kind of LV where it's very dilated, you kind of don't really know where you are unless if you put a pigtail on the aortic valve. And this is where the echo comes very handy. So we had our echocardiographer to help us with the insertion. And as you can see, the impella at the initial site was probably too far in. Then we repositioned it, and you want about 4 centimeters below the aortic valve, and this is about what it is. And this is the blood pressure that we had post-impella positioning. So I don't have the films of it, but once my first attempt was to cross with a whisper extra support wire, and it crossed pretty easy. But once the wire was crossed, this is what I had. P8. So once the wire crossed, we lost pulsatile flow. So I think it's in this kind of situation you really get to appreciate having used LV support, because this is the type of patient that would have probably coded if you didn't have the support.
Without any doubts. Yeah, absolutely.
So when this happened, we kind of went into, not panic mode, but okay, we need to get this done. And since I only had a whisper extra support in, we started troubleshooting, thinking, is there a problem with the impella, or is it just the flow and we have major ischemia? So we kind of thought, okay, let's skip on the rota and try regular angioplasty since we have a balloon in. But unfortunately, nothing would cross. We tried a 1.5, 125. We put up a guidezilla that came into the proximal LAD, and nothing would go through the lesion. And the patient was completely dependent on the impella, and surprisingly, he was awake, talking, and had no chest pain. We were having chest pain. So, ideas?
Oh, God.
Diapers? We always put them on before chip cases.
So you've been able to pass an extra support wire easily?
Yeah, it was not difficult, surprisingly.
And you're unable to bring any material?
As you saw, I had a guidezilla, I had the smallest balloon we had, 125, just wouldn't cross.
So this is balloon uncrossable lesion, right? So now you have to follow the algorithm in such cases, and you need to go. You talk about the support, having a guideliner of a guidezilla, and try to use the smallest balloon. You are not able to follow, then you may use a Tornus, 2.6 as a first choice as compared to the 2.1. If your Tornus will not cross, you may try to get down with a microcatheter and change it to a rota wire and rota that lesion.
And sometimes even if the microcatheter doesn't fully cross, you can,
you
can just shove the microcatheter in the plaque and then exchange a wire and drop the rotor wire, and then, or you use a laser. Sometimes you can use a laser. If you're fortunate to have a laser, you can use a laser.
Another option.
Two comments. Excellent intervention from Samir. We didn't think that the Tornus would have enough support because of the very eccentric calcified, and we didn't want to start dissecting the left main as well, so we didn't opt for that, despite that we managed to try to push the guidezilla as far as we could. The other issue we do, as most of you know, we do have laser. However, we had a polymer jacket hydrophilic wire down. I wasn't sure whether or not laser might damage, and we didn't want to get into sort of a loss of distal wire scenario.
So just a quick comment. It is very interesting to see that you still have the option of going to many different potential techniques because you were under ventricular support. Otherwise, this would
not have
possible.
had time. Definitely.
So that's one of the key issues, I think, justifying in this particular case.
One other option that I
Mohamed,
think we...
sometimes,
go ahead.
Sometimes it's using the wire, the rota wire, first try, and you try to cross, and it could be surprising. We all think it's a bad wire. It is a bad wire, but I mean, when there's no other options, you try it, and sometimes you just
I completely believe in what
down.
you say.
Yeah.
So let's just move on for the sake of time. Can I have my slides? So at this point, this is how the LV becomes. So we had a little bit of LV before, now there's almost no LV left. So I was pretty confident in how my wire passed, that it was smooth passage. So I decided to give the LAD a break, and I pulled back my wire to get some flow down, and it actually did make a difference. When I pulled back my wire, we did get some flow down. We looked at the IVC. There was some room for volume to optimize the impella, so we volume loaded the patient. And we started small doses of levofed. It's just important that when you start levofed, make sure you're properly volume loaded. Because if not...
You didn't put a Swan Gans to store that.
We did not put a Swan Gans.
Yeah, that's one... Yeah. I think the thing I've learned is that impella means Swan Gans. You need to be... Because as soon as you start your impella, you always have issues with volume. They start to pee like hell. And then you surprisingly you have your filling pressure that go down, and you need to fill and the only way to manage it properly is with a Swan Gans. So that's maybe one learning point in that case, is that once you have that, you can you can optimize your support.
I think also using the echo in measuring the IVC was a very good indicator, and it kind of helped us here. So after this, I brought down the rota wire, and I tried to pass the rota wire. It went through the lesion, but would not advance beyond the lesion. It was stuck in the calcium. So at this point, I thought, okay, the whisper extra support worked very well. I loaded into a turnpike, LP. I brought down the whisper. It went as smooth as it did the first time, and then I managed to haggle my way through with the turnpike. And this was the pressure post-interventions, the volume and the levofed. And then once I got the nose of the turnpike through, I brought down the rota wire, and it just went all the way to the end, and I made sure it was pretty far.
And you're using a guide liner as well, so I see you're, okay.
Mohamed, did you use the Turnpike LP straight away, or you tried the gold before?
No, I just, Turnpike LP. That's the one we have. We've had good experience with it. We like it a lot.
The Turnpike Gold is like the new Tornios. Basically, I stopped using Torno since we have the Turnpike Gold available. It's very nice, hydrophilic.
And as you can see, once the rota wire was through, we had better flow because of the rota wire is smaller than the other wire, I guess. These few millimeters made a difference. Now here you can see how tortuous it was for the rota. So we actually had to start rota in the left main.
So you're using a 125 burr here,
Yeah,
right?
this is the 125 burr.
You see, I can see it's a 125 because it doesn't have the same shape as the other wire. And a lot of operators, just to know, just to share this, a lot of operators have abandoned using that burr because it gets entrapped. So when you think you need rota, you might as well just consider go with the 1.5 right away, because the 125 is very risky to get entrapped because of its shape.
Yeah, that's
it's very
to be
different.
honest, Stefan,
diamond. It's not diamond shape.
It's not diamond shape, so it's a different. I've completely abandoned having it. I don't even stock him anymore.
To be honest with you, I always start with a 125. I've never had a bad experience with it, but I think it depends maybe on the technique you use it. I never force crossing a lesion. I always peck it and let it take its time. And
that's the key. That's the key.
The only times I've had problems is when I forced the 1.5, to be honest, but I think we have different experiences. Anyway, as you can see, the left main was very tortuous. It took some guts to burn in the left main, but we still did it. And surprisingly, it passed from the first pass. And then we didn't waste time. We took the 1.5 afterwards. And then we just, the rest was just simple angioplasty. We brought down the turnpike. We exchanged it for an extra sport wire and brought back the Guidezilla. And then I just delivered one long stent to land at the ostium. It was a 2.5/30 stent. We took our time positioning. On all this, the patient was fine, talking to us. And we tapered down the levo because we went into hypertension, actually, once the LAD was opened. So this is just the positioning. So we actually performed IVUS. I just didn't include the images for the sake of time. And there was some under-expansion at the site of the lesion, and we post-dilated with a 325 non-compliant to very high atmospheres. And these are the final results.
Very nice. That's a great example of what protected PCI can achieve nowadays in cases and patients that would have been literally executed on the table otherwise.
Did you check also left main by IVUS while having the IVUS and the
Yeah, we did definitely. That was the main reason why I took out the IVUS is to check the left main, because I was worried since I burdened it, and it was completely fine. There was no dissection, no flap, nothing. And that's the final echo. So we slowly weaned down the impella from P8 all the way to P1. Hemodynamics were fine off levo, and we still removed the impella at the end of the procedure. And successful pre-closure technique. At the beginning, I was planning to do it as a discharge next day from the court séjour, but then we brought him in the CCU. We thought it was a good idea. And then he was discharged next day without any complications, and actually saw the patient 30 days after. He saw his treating physician, and I met him in the corridor, and the guy said he's much better. No more angina, and his functional class has markedly improved.
I bet he is, right.
So our concluding remarks is that LV support is likely indicated in select high-risk patients with complex anatomy. I think echocardiographic guidance is highly recommended for impella positioning and troubleshooting during chip cases. And when you plan a chip case, I really think you need to have an open mind and be flexible about your plan, because you never know how things are going to go and how you might need to modify your plan. Thank you very much.
Thank you very much.